field for about more than 28 years or so. I'll try to give my personal nutshell experience, try not to be biographical, and share with you what I think would be a standard, now what I think should be followed. It's partly philosophical and partly practical advice. Training for arthroscopy, one must have a general orthopedic foundation. As soon as you finish your MS orthopedics, do your registrarship. I think it is to get exposed to a wide variety of pathology, which rest of your life you may not get exposed when you go into a tubular vision field. So it is important to be aware of all the pathologies and gamuts and the treatment modalities which one sees as a general orthopedic surgeon. So 3 years of registrarship, I would say, is the best part for your training, which will live you through your rest of your life, even if you decide to go into a specialized field of arthroscopy. Another thing which you must learn at that stage of your career when one is a registrar is the examination of joint. Probably the most important thing one needs to learn, examination of knee, shoulder and all other joints. We were only taught examination of the hip at that time, but present day where I'm going most of the time, I'm teaching examination of the knee or the shoulder. So it's important to learn that thing. And stop using the term IDK. We were told way back that it means I don't know. So try to start writing a diagnosis if one is wanting to get into a joint problem, specific diagnosis, not periarthritis or IDK, etc. Write and commit a diagnosis. Initially I thought, see, first when I did my arthroscopy, it was way back in 1984. That was my thesis topic. That was no video camera. There was nothing like a surgery. And that's where I got the experience of learning to do the arthroscopy myself, which I had to do it myself. There was no guidance or anything like that available way back in 1984. And initially I thought arthroscopy, like at endoscopy in other field, was meant for diagnosis. But then I was trained with Dr. Dinesh Patel, who was the chief of arthroscopy still today. Since in that day, that was about 84 or 86. When I finished my MS, I had an opportunity to work with Dinesh Patel, and he was the chairman of and chief of arthroscopy at Mass General Hospital. The first thing I was told was that diagnosis has to be clinical. It is not at that stage, it is not a modality to be used for just diagnosing knee problem. So the arthroscopy, when it started, as I said in this slide, is to diagnose knee problem. But present day consensus, I'm talking of 1986, was even at that time that the diagnosis has to be clinical, which in 90% of the cases, if you keep doing it, you will keep improving it and get a good diagnosis. And based on that diagnosis, if that diagnosis deserves a surgery, then one should do an arthroscopy. Believe me, if I was to improve my skills of one thing between diagnosis and arthroscopy, I think I still have a scope to improve my diagnostic skills. Arthroscopy I've been doing for 24 years. Diagnosis we have been also trying to do it clinically. But clinical diagnosis I still can improve much more than probably my arthroscopy skills, which maybe have some improvement scope there. So one should start practicing, and it's a performing art. The more you perform, the better you will become. One important thing one must remember is that at the time of arthroscopy, you will see lot of pathologies. Which is the symptomatic pathology? You can only know if you have clinically examined the patient and found out where the tenderness is, what his symptoms are, and where you elicit the mechanical signs. One cannot see pain through the scope. So one should be clear that one should know that this is the site of pain, and when you see that pathology, it correlates with it. But you may see some other pathologies in the joint which may not be the symptomatic pathology. So it can only be done if you know your clinical diagnosis and have examined the patient properly. Training for arthroscopy, one has to have a theoretical foundation, which should be very good. Reading books is important, and way back at that time it was only Watanabe's Atlas of Arthroscopy, which was a diagnostic atlas demonstrating various photographs, etc. At present moment, if I was to recommend one book, it should be probably Campbell's Operative Orthopedics. It gives a reasonably good amount of, the present volume gives a reasonably good amount of training information in a concise space. Way back at that time, Campbell had very little written on arthroscopy. I'm talking of 1986 or something like this. And that time Lenny Johnson's 2-volume book was there. It was very exhaustive and very extensive. But in present day time, I think if one was to look for a small, in a concise place, it should be the books. As far as the journal is concerned, it is my belief that if you are in a formative way, journals are not the best ways to learn. They do cause confusion, and for you to understand what is actual or what is factual and what is assumed and what is not true, you have to have a good experience to understand what is written in the journal. You can read what is written in the journal, but what to interpret it has to be done with an experience. So as far as theoretical foundation, when you are at a foundation stage, it is important to get into the books more than anything else. Google search, a very common quick fix method. I would very much call it a doubtful method. You get the information for 2 minutes, you have not gone into the details of it, you have not read through it, you have not spent time on looking through it. It does give information which is quick, but it is basically a quick fix information which you may not be able to sustain it for a long term, and a lot of the information which you get on Google is journal based, not always scientifically sustainable. Stay away from product monographs from companies, especially at a formative stage. It is not the right way, or getting the information or from the representative of a company who comes to you. Another step of training for arthroscopy which I found one of the best method was get attached with someone doing it well. At that point of time when I was there in 95, I used to conduct a lot of workshop. I used to go to people and give lectures, demonstrate surgery. But at the end of 5 years, I found nothing has changed there. So the best method I found was get attached to someone who is doing it well, get hands-on with him. It may not always be possible in a foreign setup, because in 95, or I mean when I'm talking of 1986, I had to go abroad and get trained there, where we will not be able to get hands-on training. But people did give hands-on training only on one condition: when they found out that the person who's coming is coming every day at 8 sharp, or even 5 minutes before 8, even though the surgery starts at 9, and is taking interest and is doing and helping out, then only will you get an hands-on experience. So have a hands-on experience. Another very important thing is, when you are training with somebody, see the equipment he is using, because that is the best guide for the equipment. If he is using that equipment and doing a procedure which you are learning, you better use the same equipment, because the companies will tell you about 20 types of punches where you need only one type of punch. So somebody you see using and is working, that is the one which you should use at that time. So see the equipment used. And for the first case, what you should do is, which you are going to do, have your trainer waiting outside. Okay, this is the best, because the most difficult part is if you start the first case and you realize that you cannot finish it. To get over that hurdle, best is to have your person who have trained you, let him come and wait outside. And on that particular date, do not keep many cases just because you have to make use of your trainer who has come all the way. This is a very important tip. Believe me, giving lectures, demonstrating surgeries in medical college, where I have gone only in one medical college, given lectures for 1 full day, demonstrated surgery for 3 days, at the end of 10 years, still nothing was happening at that stage. So this is one of the best methods which I have found it should work, and that's what is important. Try to get trained adequately first and then think of earning later. Lakshmi or Saraswati ek jagah nahi rehte hain. Get the Saraswati first, Lakshmi will definitely come. Okay, do not fall into the trap of company people coming to you with implants, offering to help you with the surgery. Stay away from this temptation, because then what you are doing is just to get the case over, not learning. Doubtful training methods, cadaveric courses, I think are still well. It gives you a reasonably good experience if you have nobody else to train you on hands-on. But conferences, I think they are good for a trained person, not for a person under training. Because conferences, we will create people that this can be done by this method, it is easy for you to do it, you see it doing it, and we end up in present day times having to see more revision surgeries than which I was seeing 10 years ago. So probably we are creating one day trained people who are adding more to the problem than solving it. Okay, but probably this is part of the whole gamut. One cannot always get away from it. One has to make whatever best one can get out of it. Company sponsored trips for learning come with strings attached. Use them if you know how not to get entangled in the strings. Okay, you can utilize them, but be careful about what you are using. Doing arthroscopy is basically a technique which is possible by the technology. It is a technique which is technology dependent. The same meniscus used to be removed, same ACL used to be done, but it is the technology which has made it easier and more precise and better to do. The technology is for arthroscopy instrumentation. Familiarize yourself with the working, care and connections. There are a lot of electrical connections, wire connections, shaver connections, suctions and anything else. I know, Dr. Saab, I was told that my lecture can go up to 20 minutes because there is no second speaker, I'm told. That's what I was told by the organizers. Okay, so I'm taking a little bit of liberty. I'll finish it in another 4 minutes or so. That's what I was told, that my lecture it's been changed, I think 2-3 times. That's what I was. Anyway, if you wish, I'll still finish in one or 2 minutes. It's not.
Okay, if the second person is not
There, he's not there. He's not there.
But I would request the speakers to stick to the time.
Yeah, I understand science. Okay, so you must familiarize yourself with the working of the equipment. People in the OT staff may not be knowing the connection cameras, etc. So it is important that when you have proper operating room environment. This slide is part of my talk which I gave on setting up arthroscopy. So 3 points which I have highlighted: use same operating room and the staff who knows when to change the saline bottle, who knows when the connection goes wrong, where to look, who knows what to do when things are going wrong. Have minimal instruments, and lot of patience is needed, especially in the initial part. If you start fighting with your instrument or with the patient or with the procedure, you will end up causing more harm than good. So patience is a very important criteria one has to learn. The minimal instruments is a very good method. I tell you, I was trained in this way back in 1986 to use minimal instrument. The lesser the number of instruments you have, lesser is your temptation to change from one instrument to another, lesser is the time you waste in changing the instrument, lesser is the trauma of putting in the instrument every time in and taking it out. And more adept you will become at doing the same surgery with the same instrument. If you have many instruments, you will not become adept at any of the instruments. Believe me, this is all what I used to use for most of my knee surgeries: a probe, a grabber, and a 15-degree up punch. Companies have got punches angled right, angled left, up swept, right swept, left swept. Believe me, it's only a temptation to keep changing it. It is possible to do most of the conventional arthroscopy work in knee, elbow, shoulder, even ankle. It is possible. Just these 3 instruments is what we used to use. It is important, you must remember that failing value of the Indian rupee has got a lot of bearing on cost viability. Cost viability is important for ethical reasons. So buy minimal equipment to keep the indication and the procedure in an ethical domain. If you have spent too much of money on buying instrumentation, you will probably ending up doing procedures which were not really required. This is a part of my another slide, another lecture which I have got, how to develop your skills. This is a complete lecture. Now this is only a small part of that, how to develop hand-eye coordination. We are all used to open surgery when we came into orthopedic. At that time, arthroscopy was not even taught in medical colleges. So we were all used to open surgery. In arthroscopy, you are looking somewhere else and operating somewhere else. An old Indian song, "Kahin pe nigahein, kahin pe nishana," probably was meant for arthroscopy. Because you are looking at the monitor and operating at the knee, and one hand is holding the camera, the other hand is holding the instrument. In laparoscopy, the space is so much that somebody else can hold your camera. You still have the option of holding the instrument in the right hand. In arthroscopy, it is the one hand has to hold the camera, the other hand has to hold the instrument. So both your hands have to work well. We teach lot of methods. There is a complete talk on developing hand-eye coordination. But the skill which no book talks about is that your both hands should work equally well. It is important to have ambidexterity if you are wanting to get into arthroscopy. It will help in other things. And it is not that at arthroscopy one has to develop this ambidexterity. One can start doing daily course by left hand, which you normally do by right hand. Use your left hand to do the same things, like brushing your teeth, if you have taken the photograph, eating your soup. And if you are still wanting to become better, untie your buttons every morning in the OT when you go with your left hand. If you still want to become better, start practicing with left hand. A very, very important skill which no book talks about is to use the left hand well. And you can develop it. It is very much possible to do it. What are the qualities? We must write proper operative notes. If you do a fracture surgery, spine fixation, everything is spoken by one word, that is the X-ray. In arthroscopy, you cannot make out, you have to make out what is written exactly. So be very descriptive. We as orthopedic surgeons are very not good at talking or writing too long, except at talks. But I feel that in an arthroscopic surgeon, he has to write the operative notes well. Very important to have a good intensity, honesty and integrity, which again I was taught by Dr. Dinesh Patel. I could see it and I could perceive it in his institution. In Mass General Hospital, he was heading the arthroscopy unit, and he was made in charge of certification for all types of doctors coming into the states of Massachusetts, which is a rare honor given to people of impeccable honesty and integrity. It's an indicator of your standing in society. Okay, so it is important to have this feature because you cannot make out what somebody else is doing. Even if you get an MRI done again, it is not possible to get the clear picture. So relying on good honesty and integrity is important for any field, but it is important. Just don't assume that just because you know how to do it well, you should start doing it. Feasibility is not to be made an indication for any procedure, and especially because it's a minimally invasive procedure, it's a lot of temptation to do it. Stay away from that temptation. Another thing which I've seen is that if a patient has got a PCL and an ACL tear, because the surgeon is trained to do the ACL, he will do the ACL and then leave the PCL. On the other hand, it is better to do the PCL and ACL, PCL first and then do the ACL at the same sitting. But this is what I've seen, so stay away from this temptation. And one must remember, it is the patient who needs the arthroscopy, not your corporate hospital or you or your investment. This can only be possible if you have kept your investment low. Another very important thing is arthroscopy commerce. In 1990, when we used to have meetings in arthroscopy, there will be 4 or 5 people attending it. Okay? The expansion in arthroscopy has occurred because of use of implant. So the implant related commerce has benefited the field. But not all procedures and all implants are with scientific foundation. Okay? So I'll share with you only one small example of science versus the commerce. Where is the difference and where we use? Interference screw is a screw used for fixing the graft, ACL graft in the tunnel. Now, tunnel is in a cancellous bone. So scientifically speaking, if you have a soft cancellous bone, you should have a hard graft to press against it. So if you have a bone patellar tendon bone graft, you may use an interference screw to fix it. But if it is a soft graft like hamstring graft, it is not an ideal biomechanical situation. It is scientifically proven by Western literature anywhere that a soft graft in a soft tunnel using an interference screw cannot hold. But still it is being used, it is being promoted, it is commercially available, it is convenient. So it is being used. So this is science versus commerce. Science is saying that it should not be used, commerce is saying it should be used, and it is being used. Another thing is that when you put an interference screw in a tunnel, the graft has to heal to the tunnel first. The interference screw is occupying part of the tunnel. So it will not let the graft heal to that part of the tunnel. So scientifically it is not, biologically it is not good. Okay? Because, and any screw which is biodegradable is not bioconvertible. Another commerce which has started occurring, present day time patient come and ask me, are you going to use disposable implant? If not, we will not do it. We will not. We want to. I said, look for another surgeon if you want a disposable implant. I don't believe in it. I think they are not as safe or as reactive as has been told to us as the metal implants are. Okay? So be careful about what the industry is saying on these things. One must know the scientific foundations. This I already spoke. Another small part is the academic colonialism. India got free from colonial rule way back in 1947. We need to get free from colonial thinking. To some extent we are coming up, but I think we still somehow believe in it. East India Company came to India for trading and then they occupied the country. I think it's the last part, last slide. I'm just over with it. There is a wealth of clinical material. I think this is a very important message which I must share. But we still rely on Western literature. If you wish, sir, I'll stop, sir, on this. We must develop indigenous technique on this point. Because our material is phenomenal and developing own technique and own implant will definitely be useful. Thank you, sir. Sorry for taking the time extra, but I think I was told it can be 20 minutes. That's
Thank you very much.
Thank you. Thank you, sir.
And if somebody is willing to ask a question, then we can allow one question only.
Sure.
Regarding bioscrew,
Mm-hmm.
the mention even in the textbooks, it can be used in a soft graft.
You are right, sir.
Experience or implementation?
No, it's not from experience, sir. It's not from my personal experience. It is from people who have done scientific biomechanical study. The interference screw, I'm not saying of bio or metal. I'm not. Any interference screw is ideally not to be used pressing a soft structure to another soft structure. It may still be used pressing a hard structure like bone patellar tendon to a soft bone, because there it will press. You can't press two doors together. You know, it's not pressing. Okay, so it's written biomechanically. It's not my belief. I don't use interference screw for a simple reason that I feel that the graft should be in full contact with the tendon. In fact, one of the last slide which I had on academic colonialism, which I had to rush through, I have developed my own technique which uses no implant inside the tunnel, and the cost of implant for any ACL is not even $20. Entire cost of implant is $20. Okay, that technique we developed in way back in 95, 96, because I started doing hamstring at that time. And that time hamstring had very little, everybody was bone, patellar tendon, bone. So all the implants were tailored to that thing. Now people have shifted to hamstring, but fortunately what we developed at that thing was biological and economical. People here are aware of that technique, which is not.
Thank you, sir.
Thank you.
Now the next speaker is Dr. Ashish Acharya from Delhi. He will speak on foreign body and the loose body retrieval, simple yet difficult. Dr. Ashish, you have to restrict yourself for 8 minutes.
Good morning, everybody. I'm here to speak on loose body retrieval, simple but at times difficult. By definition, loose body is a freely floating body within a joint. It may be osseous, osteochondral, chondral, fibrinous, or a foreign body. It may be a stable one or an unstable one. A stable one in which the position is fixed. It develops adhesions to the surrounding structure. These are usually well tolerated by the patient. The unstable one in which the loose body is mobile, and these are the ones who are symptomatic and the patient complains of symptoms. It can be found in any joint like knee, ankle, shoulder, elbow, or wrist. The common causes are osteochondral fractures, osteochondritis dissecans, PVNS, OA, intra-articular, fracture fragments, synovial chondromatosis, etc. There are a lot of causes for that. The patient usually complains of something moving within the joint, catching or locking of the joint. There's a lack of confidence in the knee. There's a sudden fall due to no reason. And if there is a foreign body, then there must be a history of an injury around the knee. If it is a large and palpable from outside, it is otherwise called as a joint mouse. You can even hear a clicking sound. The common investigations that are done, X-ray for the osteochondral fragments, but MRI remains the gold standard as it shows the chondral, fibrinous, and other things. Management only done in symptomatic patients. There is usually no conservative treatment. You have to go for a arthroscopic and removal of the loose body. It's a basic procedure in any arthroscopic joint. But I should caution you to consider this to be the simplest or the easiest of the procedure. It can be very deceptive and very frustrating one. We can go for the standard routine portals. Keep the scope focused on the loose body at all the times. If you lose it, you may not find it again. Stop the outflow cannula so that the movement of the water inside the joint is not vary, so that the loose body doesn't move inside the joint. Maneuver the loose body to an easily accessible area. For me, it's the intercondylar area. Just the size and the type of the loose body. Then you can remove the loose body either through the usual portal which you have made, or you through an separate additional or an accessory portal, whichever way you like. The size of the loose body is equal to the width of the portal that you have made. The bigger the loose body, you have to increase the incision of your portal. What is a soap bar phenomenon? It's something like trying to catch the soap within the water. I'll show you the video. It's like if you try to catch the loose body inside the joint in the water, it just slips from your grabber. There are different types of grasping instruments. We prefer the grasping instrument with a tooth at the tip. It actually helps in grabbing the loose body. If you are not able to hold it, or if you are not able to fix it, then try this. fix the loose body from outside with the help of a needle under direct vision. We are fixing it with a needle from outside. This is the inside view. Yeah. First fix it with the needle, then make an additional portal. Here we are trying to fix it. One attempt obviously may or may not be successful. You have to be repeated. Don't get frustrated over that. But ultimately you can fix it. And then make an additional portal. You should not leave any soft tissue in your portal, soft tissue breach like this one. You need to cut it through and through so that it will be easy for the loose body retrieval. If any breach, soft tissue breach is there, loose body retrieval would be difficult for you. Then hold it with your grabber and remove it. This is another video. It's a normal looking knee, but you could see carefully there is a loose body in the posterior compartment here. We have to bring it to an easily accessible area, but the moment we are going to grasp it, it will again move it because of the soap bar phenomenon. So what you can do is to push it from outside, from the posterior of the knee, so that it comes into your grasping instrument, and then you can, just like here, and then you can maneuver it through the joint and retrieval is easy. This is actually an iatrogenic foreign body during and maneuvering, or maybe because of poor metallurgy, or maybe because of old instrument, the tip of the probe broke. So we have to remove it. One should be careful not to damage the intra-articular structures while removing the loose body or foreign body of this type. Metal foreign bodies can actually damage the cartilage or any other intra-articular structures. This is the outside picture of the probe. In 2006, Krishnan and Skinner had described a useful technique in which they have changed the inflow and the outflow of the joint. They use the exit cannula as the inflow and outflow through the arthroscope. In that case, the water moves towards the scope. Along with it, the loose body comes towards the scope. So it will be easy for locating and retrieving the loose body. 2011, Gallagher and White have shown a technique for retrieving loose bodies more than 1 centimeter. They make 3 portals. One for grabbing the instrument, one for viewing, and another for the shaver, in which they go in, shave off the loose body all throughout, make it smaller, and then retrieve it through the usual portal without actually increasing the size of the portal. This is a good technique, one can try it, although I haven't tried it again. Take home message: there is no definite strategy. Every case is a new case. Do not hesitate in making the accessory portals or additional portals. Assess the size of the loose body. Bring the loose body to a secure position where it can be easily retrieved. Use proper instrumentation. Use your inflow and outflow judiciously. Thank you.
Thank you. Now this talk is open for the discussion.
Any experience with the thin copper spot segment, long one?
We could have, actually we use the grabber with a tip, teeth at the tip. So we.
Because it's not very strong for the hard loose body. Sometimes it tends to get
Sometimes maybe.
long focus.
long carcass we have used for maneuvering wires inside it, but never for a loose body inside the joint.
Any further question?
There is some experience with the broken instrument in the basic compartment.
Not quite, sir. We have just one case of this broken instrument of a probe. That was a very old probe in our hospital. We have used it and it has broken. The tip has broken, so we have to retrieve it. No experience with any other broken, and that too not in posterior compartment, definitely.
Thank you, Ashish.
Thank you, sir.
The next speaker is Dr. H.L. Nag. He'll be talking about the advancement in the management of meniscal disease, Parsons, in the treatment of meniscal disease. Dr. Nag. Dr. Nag is not there. Okay, we move on to the next speaker. This is Ravi Mittal. ACL reconstruction, comparison of various femoral implants. What evidence says. He was not there? He is there. Okay. Only one person can come from himself.
Good morning, sir. I'm here. Thank you for your invitation. I'll be speaking on the femoral implants for the ACL reconstruction. We can categorize the available femoral implants into metallic and non-metallic. Among the non-metallic, there are two varieties. The bioabsorbable, people use them because they are, we have better post-op imaging, and so-called revision is easy because these implants are later replaced by bone, but that's a doubtable issue. The other is non-bioabsorbable, non-metallic implants, and these are made of the polyethyl ketone, the PEEK implants. They are not bioabsorbable, but they are not visible on X-ray, so they have better post-op imaging. All the implants can be categorized into four varieties depending on the way they function. The intratunnel devices, they are the interference screws. Cortical fixation, that is the suture post. Suspension cortical fixation, they are the category is exemplified by endo button, and suspensory crosspin like transfix. In India, we all use autografts, the hamstring and the PTB, and these are the four companies which are available, so we'll limit our discussion only to these. What I'll say is all the implants which are available in the market have good in vitro properties. More important are the in vivo variables that determine the use, the advantage and disadvantages of these implants. They are good in vitro, that is why they are in the market, otherwise they would not have been there. The in vivo variable is the bone density. We know that it decreases with age. It is less in females and less in tibias compared to femur. The other important variable is the gap between the graft and the tunnel, and there are some implant specific variables. The interference screws and the cortical suspension devices, that means the interference screws and something like endo button, they are very popular, they are easy, they do not need extra exposure, and they do not cause any irritation because of their very presence there. Whereas the suture post or crosspin devices like transfix and cross rigid pins, they need some extra exposure and they can cause irritation due to the presence of their implants. So let's talk about a bone patella bone graft fixed with interference screws. Traditionally we have a 10 mm bone block in a 10 mm tunnel, and for this a 7 mm diameter screw is good enough. If there is a mismatch between the graft and the tunnel, that means the graft is smaller than the tunnel, you need a bigger screw. You increase by 1 mm. If you increase the length of the screw, the effect is uncertain. You do not have a better mechanical hold in the tunnel if you increase the length. And there is no difference in the outcome if you use a metal screw or a non-metal screw in this graft. And it is very important that if you take a 10 mm bone block or a 20 millimeter bone block, there is no difference as far as the mechanics is concerned. So you can afford to take a smaller bone block in this graft and have a similar result. When you are using a interference screw with a bone petal bone graft, your cancellous surface should be towards the center of the tunnel. The screw should be in front of the graft in the flexing, and the trick is to make a small notch in the tunnel or use a screw starter before passing the screw. So that makes the passage of the screw easier. The screw divergence, that means the graft, the bone plug and the screw should be as parallel as possible. The divergence should be minimal. And the key to is that if you do a anteromedial portal drilling, it minimizes the divergence because your tunneling and the passage of graft are in the same direction. And the screw should not be left protruded into the joint. That's a very common mistake, that last 1 or 2 millimeters are left inside the joint. One should be very careful while putting the screw. And what are the other implants that can be used? Other implants are the screw post fixation, that supports the cortical fixation, crosspin like rigid fix and transfix, and suspensory cortical fixation like endobutton CL-BTB. So you have an endobutton for this graft also. It could be a surgeon's choice, whatever he decides to use. They give equally good results. But in our setting, it is the problem of tunnel blowout. That means the posterior cortex is blown out and then he cannot use an interference screw in that, and then he decides to use one of these implants. In the Indian setup, most of the hospitals do not have a good inventory. So ultimately he lands up using a screw post for femoral fixation. So that's a salvage thing that can be done. But if the hospital has a very good inventory, you can go for rigid fix or a endobutton BTB CL. That's a good option if you have a tunnel blowout. Now the other graft is a hamstring graft, and for this the cortical suspension devices are the most popular. And the aim is to keep at least 20 millimeter graft inside the femoral tunnel. That's the recommended length. And then you have the various kinds of cortical suspension devices like a fixed loop length, there's an endobutton CL, variable length loop, which is the Arthrix button, which is called a tightrope, and without a loop, that's an endobutton direct. Now the fixed length loop would be difficult to use in a very short tunnel, especially if you are doing a posterolateral bundle tunnel or a enteromedial tunnel for transporter drilling for the enteromedial bundle. The tunnel may come out to be shorter than 30 millimeters. In that situation, the fixed length loop is difficult to use. So you can go for variable length loop or a loop, button without a loop. There are two main issues when you are using this device: the tunnel widening and the lateral cortex penetration. The tunnel widening that occurs because of a bungee effect or a wind viper shield effect, but even if it occurs, it does not hamper the clinical results. But the important issue is if you are happening to go for a revision, the widened tunnels make a big issue. It was also said that if you have a longer loop of the endobutton device, you will have a more windshield viper effect. But the longer loop has not shown to result in more widening as compared to a shorter loop. Now whenever you are using an endobutton kind of a device, you have to drill the lateral cortex only with a 4.5 mm drill bit, and the rest according to the graft diameter. So if you happen to by mistake drill the lateral cortex by a wider drill bit, it can affect the mechanical properties. It has been seen that if you drill the lateral cortex by a 6 mm drill bit, it has no effect on the mechanical stability. But if you happen to drill the lateral cortex by 7 to 9 millimeters, your mechanical stability is hampered and you need an additional fixation like a interference screw in that situation. Now, since the tightrope and the endobutton CL are available, there has been a big debate what to use. It has been seen that the fixed loop devices have left initial and cyclical load displacement, and adjustable loop length device, that means the tightrope devices, they lengthen under the cyclic load as the free ends are pulled into the adjustable loops. So that's the issue in the adjustable loop devices. Then you have the crosspin and the suspensory fixation like transfix crosspin. They are popular, but they require longer learning curve. The problem with the transfix is at times the nitinol wire does not catch in the hook, or there's a graft laceration while passing the transfix, or the crosspins do not enter the femoral tunnel. So the trick is to not to use a bent wire and keep the wire taut while passing the transfix, and look into the femoral tunnel that your implants would pass there. Often you have a lateral prominence of these implants. They cause irritation of the iliotibial band and they decrease the overall scores. And then the issue what Dr. Bhasin was saying, that you use an interference screw with the hamstring. You can use any of these screws, they are equally successful. It has been seen that there is a new device in the market, you have a sheath and a screw, but they have been shown that they are not superior as compared to the screws alone. The screw diameter should be equal to the graft and the tunnel diameter. Now in this situation, if you increase the length of the screw, you have a better mechanical advantage, but there is no advantage of placing the screw centrally. That means using a sheath over eccentric placement, that is without a sheath. So in conclusion, for the interference screw, material does not affect the stability. The longer screws are better for the soft tissue graft, but the longer screw have no benefit for the bone patellar bone graft. And for a bone patellar bone graft, the 10 mm bone plug is equal to the 20 mm bone plug when used with interference screws. Sheath switch screws do not have added advantage. For a cortical suspension devices, the adjustable loop length device and without loop device are useful in a short femoral tunnel. Tunnel widening does not affect the stability. Longer loop does not cause more widening, and with lateral cortex perforated, if it is 6 mm, it does not affect the stability. If it is 7 to 9 mm, it affects the stability. Adjustable loop devices can lengthen under cyclic loads. So in conclusion, all femoral implants are good for ACL graft. That has been proved by biomechanical studies. But biomechanical studies, they occur at, they are taken, conducted at a supraphysiological loads and condition. So you must remember that. So if some implant has a lower break point, that does not mean that it is bad, because that load is not going to occur in our day-to-day activities. And surgeons should be familiar and ready with at least one other option in case of a problem like a tunnel blowout. Thank you very much.
Thank you very much, Ravi. Could we ask the audience to have, if they have any question to ask of Ravi, we'll be pleased to answer them. Is there any question? Well, if there is no question, we'll switch on to the next speaker. Rajneesh Garg from Ludhiana. Rajneesh Garg from Ludhiana. Rajneesh Garg is his name, or Ludhiana? It's written in front of his name. So, the next speaker is Raghuveer Reddy. Raghuveer Reddy, are you there?
Yes.
Okay. So please talk on management of acute dislocation of the patella. There is a little change in the topic that is given in the program. It was arthroscopy in acute dislocation, but now you will be speaking on management.
So meanwhile he is setting the computer. Can I ask one question to Dr. Ravi Mittal? Dr. Ravi.
Dr. Ravi, you have a question?
Sir, as far as the interference screw is concerned on the femoral side, so we are going with the same diameter as you told, like 8 mm tunnel, 8 mm screw.
In hamstring graft.
In hamstring graft, yeah, correct. So what happens, we have said quite a few times, the graft rotate with the screw.
Yes.
So how to overcome that problem?
That's very difficult. That invariably happens. And it can even cause laceration of the graft. So that's a disadvantage. You cannot avoid it totally, whatever trick you maybe if you use a sheath, that avoids, because then your screw is not in contact with the graft.
It has
That's the only thing.
Yeah.
That otherwise it rotates.
And
You can clear your doubts later on. We had already moved on to the next speaker. You can ask Dr. Ravi later on.
Good morning, everybody. I'll be speaking on current concepts of patellar instability management. MPFL reconstruction is popular now because of low redislocation rates, reduced risk of patellofemoral arthritis, and good subjective outcomes. I got a little experience. And I was the first one to do MPFL reconstruction in India in 2005, and of course tracheoplasty. Patellofemoral joint has a low degree of congruency. In initial 30 degrees, the stability is by soft tissue constraints, and beyond 30 degrees is by bony constraints. Normal patellofemoral joint following traumatic dislocation has low rate of recurrence, whereas with some predisposing factors, they go for chronic patellar dislocation. These risk factors, tilt, increased TTJ distance, trochlea dysplasia, patella alta, they put acute threshold and cause MPFL rupture with patellar dislocation episode. MPFL is a non-isometric ligament, becomes tight in extension and lax in flexion, whereas a related retinoculum is tight in flexion, lax in extension. MPFL is a broader on patellar side. Biomechanical studies have shown that MPFL is the main restraint, and MPFL reconstruction addresses the principal site of pathology. It can be repaired, it can be plicated, or it can be reconstructed. I don't do now arthroscopy plication because most of our joints are lax and they start giving way, they become loose. So mostly I do MPFL reconstruction because it gives consistent results. It is like ACL reconstruction. We are putting a collagen and fixing on either ends. Is what the technique matters. It doesn't matter which type of fixation methods you are using. Since we are using with stiff grafts, you have to be very careful because of small errors in graft length. They can be decreased range of motion and increased patellar pressures. So again in ACL, there is like femoral point is the most sensitive compared to patellar side, and I use the patellofemoral reconstruction. If a patient patellar MPFL reconstruct more proximally, there can be loss of knee flexion and there will be excessive middle compatible pressures on facet patella. If you are placing the reconstruct more distal, there can be over tight MPFL in extension and cause extensor lag. So I use the threads of the anchor for the isometry method. If lengthening occurs in flexion, move the femoral attachment site more distal. If lengthening occurs in extension, move the femoral attachment more proximal. So this is the initial case, is a neglected traumatic dislocation. This is how the MPFL construct works. I fix in 32 to 60 degrees of flexion where patella engages in trochlea, avoid the excessive tension. And now in the 2007, Shottle has come with a good article. Now by using the radiological method, the fixation method becomes easily. The insertion point is 1 mm anterior to the posterior cortical extension line, 2.5 mm distal to the origin of middle femoral condyle, just proximal to the Blumenfeld line. And these are various collagens, various fixation methods, even they are sutured only to periosteum. All these studies, the scores are around 90 to 95, so that shows that fixation method is not important. Now presently even double bundle concept has come because it has better control in flexion and extension and better rotation stability. So this is how I make a trough on middle border of patella, put 2 anchors and fix the 20-25 mm of graft to the patella and fix on femoral side and the screw. Now the MPFL again sets have come, so the surgery has become still easy. We can use the push lock anchors to push the graft into the patella, and we are checking by isometry method, confirmed by radiological method. Again we are fixing on femoral hand with screw. So immediate range of motion is allowed. Around 3 to 6 weeks we keep the brace. Complications can be, if they are not in technical, then they can be overload, they can cause a middle facet over pressure load. And coming to patient selection, we are concerned about this group, objective patellar instability group. This group potential is they don't have instability, they have only pain and radiological anatomical abnormality. Most don't require surgery. This is chondromalacia group, painful patella. So this is the meaning. We have to select the procedures. MPFL is contraindicated with chronic pain, patellofemoral arthrosis, permanently dislocated patella, and severe malalignment. So this is the obligatory patella group. You can do in even mild patella alta or mild low-grade dysplasia. It can be combined with other procedures. If there is mild malalignment, we can use a radial release or tuberosity transfer, or you can do trocheoplasty or quadripleplasty. This is the extended indication in habitual dislocation patella. Raju Ishwaran, my friend, will be talking more on tuberosity transfers. That's why I'll just pass it now. The distal relevant. And these are the various grades of trochlear dysplasia, DIJORs. It can be treated by lateral facet elevation or sulcus deepening. I do DIJORs technique, where the new trochlea is created proximally and laterally 3 to 6 degrees. There we are decrease in correcting the TTG distance. So MPFA will suffice in low-grade dysplasia, but in sulcus deepening is required if it is high-grade dysplasia. Contraindicated in open epiphyseal plates or severe patellofemoral arthrosis. Few cases, 40 years female, twice operated, lateralis plication, still patella unstable, middle patellar glide is fine, no tight lateral retinaculum, X-ray studies, CT, cartilage status. So the MPFL reconstruction done, a lateral release not done. In past few years, there's tendency to do lateral retinaculum release is less now. I don't do much, only I do MPFL reconstruction. The 70 years female, twice dislocated, lateral retinaculum not tight, patella engages in 40 degrees of flexion. We have done a double bundle, you can see. Six months after the procedure. "25 years female, LMC till not done, still patella unstable. There is mild patella alta. Patella is still unstable. So this is before surgery and alignment after surgery. 41 years female, patella instability since childhood, lateral retinaculum tight, patella engaged in 60 degrees of flexion. So trochlear dysplasia is there little bit. So she is 41 years, now she got operated because she got a fear that she has fallen recently from steps. She got fear of breaking bones, that's why she got operated. As you can see the cartilage damage. So you have to be very careful in these cases, otherwise they can have patellofemoral pain more after surgery. So lateral retinaculum release done in this case and MPFL reconstruction and tilt is corrected. 80 years female, twice operated, lateral release, middle plication, extensive VMOplasty, still patella unstable. You can see previous surgery marks. See X-ray, there is a lot of trochlear dysplasia. That's why it is failed. So I did a trochleoplasty, MPFL and lateral release in one sitting, 6 months after the surgery. So the time of implant renal after 1 year. This is extended indication, habitual dislocation since childhood, 15 years girl. So lateral release, quadriceps plasty, MPFL done all in one sitting. So this is not an ideal case, but we can do an extended indication. Last case, 50 years female, we thought of doing TKR, habitual dislocation since childhood. This is like surgery in childhood. Knee flexes up to 120 degrees with patellar dislocation, but if you place the groove, it flexes only up to 10 degrees. These are OA changes. We thought of doing in 2 sittings because to first get the extensor apparatus first normal. So lateral release, quadriceps lengthening, MPFL and tibial traverse all done in one sitting. Now it's 6 months after the surgery. Now it is 2.5 years. Now she has delayed the total knee now. She is happy a little bit. So see how long it will runs. And coming to first time patellar dislocation is a lot of controversy whether to operate or not, but the indication is there if there is a loose body osteochondral fragment or if avulsion we can go for MPFL repair primarily. Mostly we treat it conservatively, normal or minor dysplasia, but if it's high grade dysplasia we can think of doing surgery. Always create an individual approach for each patient lifestyle, and MRI has a role in selecting the patient. Take home message will be no surgery in first time dislocation, proper planning, examination, X-ray, CT scan, and again select the procedures. And MPFL reconstruction has shown good results when used alone, when bone constraints are normal or near normal. Here a technique is important, not the fixation methods. Thanks for patient hearing. And Hyderabad will be hosting the Indian Arthroscopy Society Congress next year. Our president is here, Basin here. And we are going to have best paper awards for who submit the papers, and we'll have traveling fellowships. And thanks for patient hearing again. Thank you, sir.
You have finished your talk very in time. This talk is open for the discussion. Any question?
With this thing, you showed a case of trocheoplasty. Now, there are some cases which are doubtful trochlear dysplasia, doubtful trochlear. So, would you always recommend going for trocheoplasty straight away, or do the smaller? Because trocheoplasty looks very invasive procedure. I haven't done it, or have any experience with it, but it looks quite an invasive procedure to do.
Yes, I agree with you. Even that's why patient selection is important. Even MPFL reconstruction is done alone. Even in mild trochlear dysplasia, results are good. See, not only when if you have high grade dysplasia, if you have split type V-shaped trochlea, in those cases it is there. I agree with you.
Thank you. Dr. Raju is here. Dr. Raju is not there, then I would like to invite Dr. Raju. So I would like to invite Dr. Amarjeet Singh to speak on TPI spine level. Yeah, the speaker is in place of Dr. Arun Gupta, Dr. Amarjeet is.
Yeah, good morning. I'm here to speak on arthroscopic fixation of anterior tibial spine. So this is the classification, type 1, type 2, and type 3. And these are the various treatment options. Conservative is done for type 1 and most of the type 2 cases, but